Invasive methicillin-resistant Staphylococcus aureus, also known as MRSA or MRSA, was once rare and confined to institutions, but has now become a major public health problem. MRSA in the community is widespread, and therefore everyone is at risk. Most community-acquired MRSA infections are skin infections. Current estimates suggest that 12% of all clinical MRSA infections are community-associated. Factors that have been associated with the spread of MRSA skin infections include close skin-to-skin contact, contaminated items and surfaces, and crowded living conditions. People may be more at risk in settings where these factors are common, including athletic facilities, dormitories, military barracks, correctional facilities, and daycare centers. Public health professionals, school athletic departments, coaches, trainers, and others concerned with community-acquired infections are looking for ways to educate the public about MRSA and address misunderstandings about its prevalence, the way it is spread, and how to treat those who become infected. The goal of this program is to develop a change model that incorporates thought, culture, and practice by identifying evidence-based measures, assessing a practice against those measures, and implementing interventions for performance improvement in addressing the incidence and spread of MRSA in the community. To address the spread of MRSA in both healthcare-associated and community-associated areas, an expert panel was convened that included Dr. Nancy Davis, Executive Director of the National Institute for Quality Improvement and Education, Dr. Ari Robichek, Assistant Professor, Internal Medicine and Infectious Disease for North Shore University Health System, Dr. Jennifer Beard, Assistant Program Director, Internal Medicine at Riverside Methodist Hospital, Dr. Ian Baird, Infectious Disease Specialist at Riverside Methodist Hospital, Dr. Marcus Topinka, Chief, Emergency Department at Doctors Hospital, Dr. Maishika LeMay Williams, Medical Director and Assistant Health Commissioner for the Columbus, Ohio Board of Health, Dr. Sean Kerger, Doctor of Sports Medicine, Ohio Health, Lita Jo Hinman, Infection Control Coordinator for Riverside Methodist Hospital, and lead faculty Dr. Richard Snow, Medical Director, Performance Improvement, Doctors Hospital. Athletes are a particular at-risk population that has received considerable media attention in recent years. Participation in athletics can increase the risk of MRSA transmission through close personal contact, including direct skin-to-skin contact, and the increased risk for skin abrasions, as well as environmental and situational exposure, such as the use of contaminated shared equipment. As we discuss the particular challenges MRSA presents to those participating in athletics, keep the following question in mind. What elements are needed to effectively respond to and control the spread of MRSA in an athletic setting? A. An understanding of how MRSA is transmitted in athletes. B. A plan to teach proper personal hygiene, proper cleaning of shared equipment and spaces. C. Adhering to proper management protocols for athletes with active infections. D. All of the above. Keep your selection in mind as we discuss the challenges of managing MRSA in athletic settings.
And swab a wrestling mat and you could probably discover 4 or 5 species not identified anywhere else. That's certainly a great nidus for infection. You've got lots of skin-to-skin contact, lots of abrasion, hot, moist areas typically, just a beautiful agar plate for all kinds of things. In the athletes, we have environmental and situational exposures.
And if you look at all the outbreaks in Ohio since it's been reportable, sports teams have the highest level of outbreaks in this state. I think 36% of the outbreaks are sports teams, followed by 24% in correctional facilities.
Another factor within the sports medicine community is that you've not just got the physician and the athlete interacting, you've got the coaches, you've got the athletic trainers, you've got a whole host of individuals who have an opinion and you need to work with in the future. We don't have good recommendations for when is an athlete clear to return to play, be in the locker room, all those kind of things. So again, we do what I feel is prudent, what is reasonable. Once the athlete has been on antibiotics for 72 hours with clinical improvement or has had a drainage with clinical improvement for 72 hours, no new lesions, the use of barrier dressings. The dressing can come off in most of the sports medicine literature when you've got a hard, firm crust over the lesion, and again, this is typical of all kinds of infections. But at the same time, I can tell you that in sports medicine anyway, even if it's got a crust, we're keeping it covered. because we don't want secondary infections overlying that crust, again, with the friction and the trauma that exists in the sport.
Managing the health of athletes requires constant vigilance. Remember that not all athletes have uniform access to team physicians and trainers, and may seek treatment through emergency rooms or family physicians. Keeping that in mind, how do you assess progress towards recovery, and how do you protect the athlete and other team members?
I guess I hear what you're saying when there's an athletic physician or trainer involved, but you know, we get a lot of these athletes that don't have access to that type of trainer at school. They might have gone to their ER and they got IED'd, and then you know, the coach says, well, they're not on antibiotics, why not? And they kind of panic, and I try to remind them, you know, IND is the gold standard. They really don't need antibiotics.
They can, as long as it can be adequately wrapped, and that wrap or dressing doesn't represent an advantage for them over their athlete, as long as the wound can be closed.
The Wrestling Association, to my knowledge, is the one group that really has some good criteria on what they do. They do skin checks before their meets. And
absolutely. No,
they're well organized.
They do a well-organized job, and I'll tell you one of the other keys that you've reminded me of, thank you very much, is the importance of monitoring these lesions with the same set of eyes. That is critical, and if you've got multiple team physicians working through a locker room, it's very important that you either photograph or have the trainer there so that you've got someone who can say, this is what it looked like yesterday, this is what it looks like today. Sometimes the curse and the blessing of sports medicine is serial exams. You're going to see these people daily. Is it better yet? 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 And the benefit, of course, is that you get to see the spectrum and the continuum of improvement, or at least you hope for improvement. But it only works if you've got the same set of eyes. And I can tell you, I try to be as precise with my words and my documentation as anybody. Written word does not communicate what a picture or the same set of eyes looking at it will do.
When it comes to wound care and infection, incision and drainage of the lesion remain the gold standard of treatment. Continuity of care is also critical. To ensure consistency, remember that deciding on policies regarding infection in advance helps eliminate exceptions to the rules, assures buy-in from participants, and aids in compliance with the policies.
There's a lot of people that can get a good process and good policies organized. It's not just the patient and their family, it's the extended family that exists within the sports medicine community, the trainers, the athletes, the athletic directors, the principals. Everybody really needs to be involved on this, and you absolutely benefit from coming up with the game plan before the infection arrives, because the last thing you want is any indecision or confusion as to where we're all going.
In response to the growing concern over MRSA, many organizations across the country have published guidelines which can help schools establish their own protocols for preventing infection among athletes. Dr. Kerger covers some of those protocols in the next section that can help you establish your own response plan.
The programs that the Ohio Department of Health have put out, and some others that I'll mention in a moment, have wonderful, I think, guidelines. These are supported off the CDC website for helping groups find their way through these things. Already brought up with the water bottles, proper equipment. Towels are a big thing. Towels are clean until they've got something physically that you can see, right? And that's the way athletes go, and it's amazing. I'd love to test the
wash my towels.
I'd love to test the nasal passages of these athletes and see, is there like any cranial nerve 1 function here at all? I mean, I can smell that down the hall, and you're telling me this is the thing you're still using because you don't want to take your towels home and wash them. It's amazing in that regard.
Can you talk a little bit about ice baths and what you think about
Ice
those?
baths, hot tubs, all of these need to be cleansed. Athletes who have open wounds should not be using them until that wound has sealed and either crusted over or become a, what we call a soft seal on that lesion. And in most of the protocols that I've been mentioning, the Virginia Tech protocol, the ones that come out of Tacoma I'll be speaking to in a moment, have very strict criteria about athletes with skin lesions being able to use those group things. Even if you don't have a lesion, you should be showering and cleansing yourself before using those devices in those situations. And regardless of who's been in there or not, they all get the scrubbing of a lifetime at the end of the day, and then are kept covered with whatever until the following morning. Absolutely. It's a great point because we think of these as medical devices. Obviously they're clean, and we're not going to clean it in between 50 people coming through. It's just not an option. So how best to address that? Correct treatment, including follow-up to document resolution, is critical for your sports athletes. Again, this is a subset of the community that we know has a predilection for this situation.
Given what we now understand about the elevated risk of MRSA infection in athletes, how do we proceed?
Don't assume that just because they're young and they're healthy and they feel better and that they want to get back in the game, that they won't tell you that it's better. You need to look at it, and hopefully again with the same set of eyes. Absolutely attempt to reduce unnecessary antibiotic use, and I really want that to be a target of this presentation. I do spend quite a bit of time on these slides talking about if you choose to use an agent, what you should be using and the issues, but far and away incision and drainage is more than adequate, and that is the standard for dealing with such lesions. Otherwise, it's very similar to the community-acquired prevention as we've talked about before. The Virginia Tech policy is online. The website is given there. You can download the PDF. It is a living document, and so it's constantly being updated. I'm not suggesting that it's perfect for all circumstances. They do some things that other schools simply will not be able to do, but I do think it gives groups a format and a structure to work from and develop their own protocols. The second reference there is the Tacoma Pierce County. This is out of Washington State. This is a link that you can find off the CDC website. And the CDC, by the way, does have a wonderful website specifically for athletes in MRSA. And I really feel like they've done a good job of collating materials together. This particular reference I make because it's available and it's designed for middle and high schools. It's got terminology and language for what do you tell the custodian, what do you tell the athletic director, what do you tell the principal, what do you use for the community, what are the issues that are germane to the middle school and high school athlete. And I think this is a wonderful, again, a template, someplace to start, see does this apply to your community, and are these reasonable sections that we can do.
While setting a policy to handle active infection is important, confirming the presence of MRSA is essential for determining the appropriate interventions. Dr. Kerger has compiled a set of general ambulatory guidelines for diagnosing MRSA in athletes.
You have to have a high index of suspicion, especially if you've got the classic spider bite and it hasn't developed into an abscess yet. There is still, in my opinion, not much role for nasal swab testing of the patient versus doing a culture of the wound or following your other instincts on the physical exam with that. If it's possible, perform the incision and drainage. Incision and drainage, again, is your gold standard. I can't emphasize that enough. Find out what your resistance is in your community because, again, across this nation, it's all over the place as far as what resistances exist in the community.
Keep in mind that athletes have a higher incidence of MRSA infection than the general public, and effectively preventing the spread of infection in an athletic setting requires special considerations.
For the athlete, all of the same thing for the ambulatory, except if you recognize that you're sharing common spaces, you're going to have a higher incidence of MRSA even than in the general public. If you're operating within a competitive athlete environment, you can assume that you're higher than that community rate, and you should start with MRSA-sensitive antibiotics first line if you need them. If you identify more than one athlete, I would talk in advance with your teams, your coaches, your athletic department, and whatnot about how we're going to handle this. I think you need nasal and skin swabs for identifying the athlete population for the issues that we've gone over, and axillary and groin swabs are probably warranted. Is nasal adequate? And we're finding that, at least in the athlete community, it certainly does not seem to be. A key, again, we don't want to be under the heat of the moment when we're trying to make pressure decisions and how we're going to handle that, so develop and follow those policies. Those policies should include the EHS, Environmental and Health Safety regulations for your institution. Obviously, we want everybody on board with this. We want them all marching in time, if you will, and those of the CDC, as well as those recommendations for the equipment that you're addressing. So you might need to contact the helmet maker, you might need to contact the maker of your pads to figure out what agents might be safe to use in these circumstances. Suggestions for the athlete, basically coming down to good hand and body washing guidelines. If you've had recurrent outbreaks, perhaps look at the soap solutions that you're using. Should you be switching to an alcohol-based hand wash solution, but using regular body soap in the showers so that you've got both agents going at the same time? Don't use refillable reservoirs within these soap dispensers, as those can become colonized and actually become a nidus as well. A carry bag or liner specifically for dirty gear. I think one of the biggest issues we have with our athletes is they take off their stuff, they take their shower, they dump it in the bag, they take it out of the bag, they do a great thorough job of washing in 160-degree temperature, and then it's right back.
Think about all this football equipment where they've torn out all the lockers because there was a kid that had MRSA, so they tore out every locker in the locker room.
Yeah.
So kids have to drag everything back and forth every single day.
So hopefully, we will get new antibiotics if they become warranted to help us with more of the invasive infections, not simply the abscesses that we see so commonly. That the guidelines do work. I mean, when we followed these and we put them to the test, we do see that we can make positive improvements against this.
In our community, we did have a situation with one of the school districts related to MRSA.
We had a situation where we had a student presented in the clinic with a suspicious lesion on one of his limbs. Diagnosis ended up being community-acquired MRSA.
In the back of my mind, I always wanted to be prepared, to know that, yeah, this may happen to a student, it may happen to an athlete, because it has evolved from the hospital-based bacterial infection to a community-based now.
MRSA is something newer. It's not a word that I knew 25 years ago or even 15 years ago.
There were 3 different school buildings that had 3 different cases of MRSA, and in an effort to provide information to the parents and provide the education about MRSA, there was an article in the newspaper.
It's intriguing and amazing to me just what a huge piece fear can play.
The first call that we received was from a concerned parent who happened to read this article.
We had parents calling into the school wanting to come and pick their children up because we had this big bad bacteria, in our school.
One kid getting that is one too many.
We did have another case pop up a couple weeks later.
It gave a perception that there was a big problem.
I think the role of fear was definitely there, but it has evolved into what we call teachable moment.
One of the first steps when we learned of the diagnosis was to call the health department to gain their guidance.
We have a great relationship with all the school nurses in the district. You have to be very specific when you're communicating with the parents, explaining that this is not an outbreak. We know that there are cases that are not related to each other, but rather we're using this as an opportunity to do the education.
Although this is something not to take lightly, it's something that is very manageable if you take a team approach and you focus on early detection and early diagnosis and early treatment. We started out with working with the custodians to make sure that the area was being cleaned properly and to make sure that the agents used were effective in killing MRSA, and last of all, that the agents being used were being used according to the manufacturer guidelines so that we were killing all of that bacteria. Second of all, too, we also work in conjunction with our athletic director and our coaches.
MRSA is a situation that we believe is treatable through procedures and how we choose to approach it.
I think the situation that we had here enhanced the team approach. We had a strong team approach.
The key takeaway regarding MRSA is we have a lot of general information and resources about MRSA, but really custom making it or tailor making the information to the group that you're addressing to is very important.
One of the things we were most proud of was that with that second incident, we did not have the community panic, the parent uprising, and the parent concerns coming in. The team got together, once again continued to address the situation, and things went like clockwork.
We've covered some of the ways in which MRSA can spread and some practical strategies for preventing it. Remember that education about the role of personal hygiene, the proper care of equipment, and the cleaning of shared spaces can prevent misunderstandings and help eliminate overreactions in the ineffective use of resources that fail to address the problem of MRSA transmission. Let's revisit our key question. What elements are needed to effectively respond to and control the spread of MRSA in an athletic setting? A. An understanding of how MRSA is transmitted in athletes. B. A plan to teach proper personal hygiene, proper cleaning of shared equipment and spaces. C. Adhering to proper management protocols for athletes with active infections. D. All of the above. The correct answer is D. All of the above. Let's review the key learning points covered in this section and the ways in which these points affect our change model, incorporating thought, culture, and practice. The thought change is that MRSA infections are treatable and preventable. The culture change would include knowing the prevalence of MRSA in athletic settings and educating coaches, athletic directors, and school officials about appropriate response measures, as well as educating students and parents about ways to prevent the transmission and spread of MRSA. Some of the effective practice changes we have discussed are instituting measures to prevent the incidence and spread of MRSA among athletes in the community, and educating the public about preventing the spread of MRSA. The key learning point in this program is that information and education combined with simple proactive measures can go a long way towards reducing and preventing the spread of MRSA within the community. Specific performance measures and tools that will help you navigate the change model, thought, culture, and practice are included in the resources section of this toolkit.